Yeah, thank you so much for inviting me, Katie. And I really hope that you're going to find the talk interesting. Katie gave me a very long title, which was talk about the relevance of Ehlers-Danlos syndrome, which obviously is a bit of a mouthful anyway, which I'm going to refer to as EDS, postural orthostatic tachycardia syndrome, which I'm going to refer to as POTS, and mast cell activation syndrome, which I'm going to probably still refer to actually as mast cell activation syndrome, and its relevance to headache. Just to sort of tell you a little bit about myself, obviously Katie explained how we'd met, but like her, I've been a GP. In fact, we both trained at the same medical school, didn't we? But I think you were slightly ahead of me. And so I worked as a GP in Bucks for 25 years. And more recently have developed this interest in EDS, POTS and mast cell. About 11 years ago, I trained in clinical hypnosis. It was something that had always interested me, and sort of now developed more of a portfolio career, having stopped my NHS general practice. And so I'm spending my time looking after patients with EDS and also doing cognitive behavioural hypnotherapy. I'm a medical advisor to EDS UK, and I'm also a GP advisor to the Autonomic Charitable Trust, which raises money for research into autonomic problems. And as you'll realise as we go along, I'm also a patient. So POTS, EDS, MCAD, which actually is synonymous with MCAS, I think this is a really good slide to start with. I don't know what that is, so you don't have that. And this is what I hear from quite a lot of patients that come to see me, is that clearly there is a real educational need here, because the patients are often very knowledgeable about their problem, but their own NHS GP frankly doesn't have a clue. And I think it's one of those situations where many doctors, if they don't really understand something, then they will tend to say that somebody hasn't got the problem. And this is what we're really up against. And so it's really lovely actually to have the opportunity to talk to you, and hopefully as time goes on, I will be able to talk to more GPs. So Ehlers-Danlos syndrome, EDS, was probably described firstly by Hippocrates as early as 400 BC as a sort of bruising and bleeding disorder. And then it was recognized by Ehlers, who was a Danish dermatologist, as a distinct entity in 1901. And then Danlos, who was a French dermatologist, who suggested that skin extensibility and fragility were cardinal features of this syndrome. And so the name Ehlers-Danlos syndrome was coined in 1936. And it's a shame, really, I think, that it's called this, because so many people can't even pronounce the name that, you know, you kind of feel you're on a back foot with this condition before you even get started. So what do we know about EDS? Well, what we do know is that it's a heritable connective tissue disorder, and it's related to abnormal collagen. And currently, we've identified 13 different types. And there are genetic markers for all these types. Unfortunately, there is yet to be a genetic marker for the most common type, which is the one that I'm going to concentrate on with you tonight, which is the hypermobility type. It is a really neglected multisystemic disorder. And what we're beginning to recognize is that this is actually quite common. So if you look in the literature, it's cited as occurring in probably about 1 in 5,000 patients. The people who are involved with Ehlers-Danlos, we now believe that actually it's probably affecting 1 in 500 people. So this condition gets missed all the time. And one of the problems is that people are just not educated. They don't know what they're looking for. And probably the most important thing that is an issue with this is the fact that you can't just do a blood test and say somebody's got hypermobility EDS. We don't have a clinical biomarker. And so you're relying on doctors having their wits about them and understanding the sort of nuances to this, and the sort of diverse clinical features in order to make a diagnosis. And this is what makes it complex and difficult to get through to people. I was just trying to remember what I was taught at medical school about EDS, and as far as I remember, it was literally just one slide, and my memory tells me that it was literally somebody who had stretchy skin, loose joints, and maybe had a sort of marfanoid habitus. I don't know what the rest of you learnt about EDS at medical school, but that was certainly what I remembered. It was literally one slide as far as I can remember. So Ehlers-Danlos syndrome can potentially affect the whole body, and it's collagen. It's an inheritable disease of collagen, and collagen, as you probably know, is the most fibrous structural protein in the body, and it's everywhere. So you find collagen in skin, tendons, bones, cartilage, eyes, blood vessels, and connective tissue acts as a glue, and it supports and holds the body together. And this slide is quite useful, I think. I show it to patients sometimes because I think it's a really good way of illustrating what's happening with connective tissue. So you sort of basically getting holes in it. It's just not holding things together. So the way I kind of think of it is that people start bursting at the seams in different places, and this then potentially causes lots of different problems for people. And so if this connective tissue disorder is everywhere, or potentially it can cause problems everywhere, then it sort of begs the question, doesn't it? Could this be the cause of those heart sink patients that we see in general practice that present to us with multiple medically unexplained physical symptoms? So I thought I would just briefly run through a sort of timeline of hypermobility EDS, just so you get a sort of idea of how we are actually now starting to make some progress with understanding this condition. So it wasn't really very well described until certainly the start of the middle of the 60s, where it was recognized as being a condition where people struggled with musculoskeletal pain and joint instability. It was then recognized in 1970 that there was an overlap with hereditary connective tissue disease. There was an effect on skin very often, and there was often a marfanoid habitus. In 1980, it was recognized that there was an association with uterine or rectal prolapse. And then in 1990, it became clear that a lot of these patients were really struggling with chronic pain, and also, interestingly, seemed to particularly have problems with anxiety and phobias, which particularly interests me because I see a lot of patients with anxiety and phobias with my interest in hypnotherapy. And we now know, which I find fascinating, that if you scan the brain of people who've got hypermobility EDS, they have a larger amygdala than the normal population. This is some work that's been done in the last sort of 5-6 years by a psychiatrist at Sussex University called Jessica Eccles. And so we tend to go into sort of fight flight very easily and startle very easily. And when I ask patients whether they startle easily, they always sort of look at me really surprised, as if to say, well, how do you know that I startle easily? But it is something that you just ubiquitously seem to see in these patients. I mean, I'm certainly one of them, you know, struggling with this myself. And then in 2004, it became clear that there was this link with POTS. And we're now beginning to recognize that a lot of these patients are really struggling, and some of them are really disabled, actually. So when it comes to your particular interest with headache, it's really more recently that we're beginning to really see that there's this link with lots of issues going on with the neurological system. So we became aware that there was this link with Chiari malformation. There's a link with craniocervical instability, with tethered cord, and more recently, we're recognizing that there is also this association with mast cell activation. I thought I would just talk about myself for a little bit. I ended up having an article written about me in the Daily Mail. Now, I really don't like the Daily Mail, and I'm almost embarrassed to say that there was something that I contributed to something in the Daily Mail, but I have a friend who's the health writer for the Daily Mail, and when she found out what had happened to me, she said, I really think I should be telling your story. So I said, well, I don't mind, Louise, but you're only going to do this if I have editorial control over the story, because obviously there's always a risk with these kind of tabloid newspapers that they can say all sorts of things and get things terribly wrong. But she did a really amazing job, I felt, in telling the story about what's happened to me. So I thought I would just spend a couple of minutes now just reading to you what she wrote about what happened to me, because I think it really explains what patients are up against when they're trying to deal with these problems. So I'm just going to read it as she wrote it in the Daily Mail. For 20 years, GP Kate Barnes has lived with chronic headaches and pain. I was struck by neck and shoulder pain after the birth of my eldest son, now 22, and by the time I had my second son 17 months later, anything that involved using my upper arm and shoulders was painful, she says. Her neck and shoulders even hurt when she loaded the washing machine and the dishwasher, in fact. Kate, now 52, also felt chronically tired. She assumed these were just normal muscle aches, exacerbated by the tiredness so many women feel after having a baby. Kate's third son was born 16 years ago. Yet as her boys grew, the pain and fatigue didn't budge, and she noticed an increasing number of other apparently unconnected symptoms. Though sporty as a child, she played county tennis, by 30, Kate noticed she'd lost much of her stamina and would become breathless walking up even gentle hills. Weirdly, I found warm days, sunshine, and hot rooms completely sucked the energy out of me, and when I stood for any length of time, I'd feel as though I was going to faint, she says. I was plagued by migraines and would get out of bed each morning with my whole body feeling sore and stiff. My eyesight also seemed to be appalling in the evenings. I'd drive everyone crazy at home by insisting all the lights were switched full on. And her digestive system became increasingly unsettled with bloating and constipation and sometimes diarrhea. Despite being a GP, Kate, who lives in Buckinghamshire, struggled to put a finger on what was happening. I decided to blame stress. I'm the sort of person who has always thrived on being busy, and I told myself I just had to get on with life, she says. I looked so well that anyone hearing about my symptoms could be forgiven for thinking they had a complete madwoman on their hands. During her 30s, Kate had referrals to 2 different rheumatologists and a pain specialist in a bid to find a diagnosis, but her blood tests were normal. Then 2 years ago, on her 50th birthday, she vowed to do whatever it took to sort things out and decided to see a neurologist. Scans and tests revealed unusual neurological signs, and she was referred to 5 top London hospitals with different specialist neurological investigations. Eventually, Kate found herself in the consulting rooms of Professor Christopher Matthias, an autonomic and neurovascular medicine specialist at St Mary's Hospital in London. After reading her notes and noting the way she was trying to keep her head and body reclined in the chair to stop her dizziness and nausea, he tested her for hypermobility, that is double-jointed or excessively flexible joints. He then told her, "I think I know what's wrong with you. You've got Ehlers-Danlos syndrome." EDS is a genetic disorder in which the connective tissue which supports, binds, or separates tissues or organs is weakened by a genetic mutation. The classic signs are excessively stretchy or fragile skin, or very flexible or loose joints, which dislocate easily. We all remember the kid at school who could bend their thumbs back to touch their arm. However, increasingly, experts believe the condition can cause more diverse symptoms, as the blood vessels, organs, bones, and even the digestive tract can all be abnormally fragile and stretchy too. This can lead to a wide and seemingly unrelated range of symptoms, which is why, as Kate discovered, it's so difficult to diagnose. Even though hypermobile joints are usually the one underlying factor, the degree to which the condition affects patients varies. You can have hypermobile joints and be perfectly healthy, better than healthy. In fact, because you can do things other people can't, said Professor Mathias, who explains that the condition is not uncommon in top athletes, gymnasts, and ballet dancers. There are many different forms of Ehlers-Danlos affecting different parts of the body. Hypermobile joints may be the least of your problems. For example, in vascular Ehlers-Danlos syndrome, blood vessels can become fragile and rupture, while a kyphoscoliotic type can lead to curvature of the spine. But the linking factor is the abnormal or fragile connective tissue, which can result in gut problems, sluggish digestion, constipation and bloating due to weakness in the gut wall, hernias, as well as uterine or rectal prolapse, heart valve abnormalities, varicose veins, bladder problems such as UTIs and incontinence as the pelvic floor collapses. It might also trigger impaired proprioception, where you can struggle with balance, and loose connective tissue around joints can lead to premature osteoarthritis. Some patients have problems in the autonomic nervous system, which governs the body functions we don't have to think about, such as the control of blood pressure, heart rate, temperature, and the gastrointestinal tract. This can lead to rapid heartbeat, dizziness, excessive sweating, and an inability to cope with heat. The nervous system can also become sensitized, causing pain and fatigue. But because there are overlapping symptoms, it is almost impossible to gauge how many people are affected by Ehlers-Danlos syndrome that involves autonomic dysfunction. Although Professor Mathias speculates it may be as common as Parkinson's, which affects an estimated 1 in 500 Britons. Professor Mathias says the way symptoms can occur over time, as in Kate's case, is typical. They're usually triggered by an event such as surgery, infection, or even traumatic childbirth, which shocks the body and triggers problems with connective tissue. And Kate now thinks the glandular fever that she had as a medical student could be the culprit. There is no single test for Ehlers-Danlos syndrome, and diagnosis relies on taking the patient's medical history and examination. And if, like Kate, you don't have particularly hypermobile joints that cause problems, you may never be diagnosed. As she points out, if you're struck, as I was, with a strange combination of symptoms, you can easily be put into the melting pot of chronic fatigue or dismissed as a hypochondriac. There could be thousands of people struggling with chronic pain but undiagnosed. And doctors, even specialists, may not be fully aware that hypermobile joints could be an important sign of the condition and could explain a patient's other symptoms. As medical students, we were shown one slide about the condition, and if you were dozing through that particular lecture, you could very easily miss it, says Kate. Indeed, it was only by chance she ended up seeing Professor Mathias. A previous specialist had suggested a lumbar puncture, in which a syringe is used to draw fluid off the spine, and this was to check for multiple sclerosis. But Kate had a severe reaction to the process. When the needle pierced the connective tissue surrounding her spine, the tissue was so thin and brittle as a consequence of her condition that it ripped rather like cellophane. And afterwards, Kate was struck by a persistent, debilitating headache and spent months bedridden. Because of these problems, she was then referred to Professor Mathias. When he read about the lumbar puncture and saw how Kate was sitting, leaning back slightly to stop her dizziness, he suspected Ehlers-Danlos syndrome. Tests on her joints and autonomic system did confirm his diagnosis. It was such a relief to finally understand what's been happening to my body, says Kate. Even though there is no cure, a proper diagnosis is still important, says Professor Mathias. It means we can tackle each symptom separately and, if needed, get the correct specialists involved. Kate now takes medication for low blood pressure, her unsettled digestive system, pain, and sleepiness. She also finds that CBT and hypnosis, which she practices and teaches, helps her deal with the symptoms and reduces stress. Kate has taken a special professional interest in the condition, and GPs are now sending their more complex cases to her. Interestingly, she has also picked up 5 cases in her small NHS practice alone. So hopefully that's just given you a flavour of one story in amongst lots of others that I'm now beginning to hear that are all unique and different, but with overlaps about how diverse and problematic this condition is. So moving on, I was lucky enough, having sort of got involved with finding out more about the condition through the EDS UK charity, to be invited to New York. This was, I was diagnosed with the condition in 2014, and it was in 2016 that I got invited to this international symposium that had been set up by this new charity called the Ehlers-Danlos Society, which is an international society. And there's me in the front row, not at all because I'm important, because I really wasn't important, but at the time I was feeling so terrible that there was no way I could stand with the POTS type problems. So I was sitting, but I was determined to be there. And it was a really, really interesting symposium because we were able to sort of sit round a table and start talking about, well, what were we going to do about these patients who are really struggling and have really been, I would say, maltreated really by the medical profession, but largely through ignorance. The Ehlers-Danlos Society logo is a zebra, and I think it's quite a clever logo actually, because it's a way of explaining that with these connective tissue disorders, every patient with hypermobile EDS is different. They have unique symptoms, and of course that's what makes it so challenging to diagnose. And as you're probably aware, every zebra has different stripes, so they're sort of the same, but they're also not. So when we set about trying to look at how we were going to move forward with this, it was very interesting, because if you look at the rheumatologists through the last sort of 20 years, the rheumatologists that have been diagnosing it were calling it joint hypermobility syndrome. But the geneticists had been going along a sort of parallel track, and they had been calling it Ehlers-Danlos syndrome. And it was recognized that actually the two things were synonymous. So it was decided that actually the JHS should be dropped, And we also recognised that there were a lot of individuals that had hypermobility related problems that didn't really fall into the heads group, which I'll come on to in a minute. But they definitely had some problems and they needed to be kind of accounted for. So these patients, we now give the diagnosis of hypermobility spectrum disorder to. And I think this is a really good slide. It's not my slide, I've just copied it, but it just is a really good way of illustrating to you the spectrum disorder, really. I think what's really interesting is that 20% of people are hypermobile. Now, the majority of hypermobile people, I mean, probably some of you are hypermobile, but the majority of hypermobile people do not run into these problems. And as Prof. Matthias said, and you know, I related in the story that I just read, you know, it can be a huge advantage. You know, you tend to get some of the really good sports people are hypermobile. So there's a sort of evolutionary advantage to it. But the problem comes when people tip into this sort of illness. And what certainly I've recognized through seeing all these patients is that there's a trigger. So with me, I really do think it was glandular fever as a medical student, because I was really sporty and I had glandular fever and I just was never able to pick up after that. And then clearly the lumbar puncture, I just decompensated so much further. And when you listen to people tell their story, there is nearly always some trigger. It often is some sort of virus, but equally it can be something like a whiplash injury, any other kind of physical trauma, but also mental trauma. And so we obviously had to make some decision about how we were going to put people into these different pots. We needed to have some sort of firm diagnostic criteria to use, a template. And so this is what we came up with. And it's really a work in progress. I don't think it's completely right yet, but it's a start. And so what we were recognizing was that you could not rely on what most GPs had come across, which was something called the Byton score, which I suspect that you're all familiar with. Byton was a South African physician, and in fact his score was, it was originally really meant to just be used as a sort of research tool, but somehow it just ended up being used as a way of trying to work out somebody who was hypermobile and who wasn't. But there was a real drawback to the Byton score, because actually it's only looking at a few joints. You probably remember it looks at the thumb, the little finger, whether you can put your feet flat on the floor, whether you've got hypermobile elbows, whether you've got hypermobile knees. But if you're somebody like me, I just am not hypermobile, particularly in those joints, apart from slightly in my elbows and knees, but I'm actually very hypermobile in my neck and shoulders. So we realise that we're missing a whole group of people here, because, you know, I feel quite embarrassed in a way that, you know, I was this GP for all these years and I couldn't actually work out what was wrong with me. But clearly, if you don't have a really high Byton score, then it's quite difficult to suddenly think that you're kind of going to be in this hypermobile category. And I was like gobsmacked, to be honest, when I was given the diagnosis. The other thing that we find is that if you are seeing people who are sort of getting into their 30s and 40s and older, they often are very stiff. So they may have been hypermobile as a child, but actually because of the enormous amount of movement, the muscles tend to go into spasm as a way of protecting the joints. And so actually a lot of these patients are stiff, so they don't actually particularly have a high Byton score at the time that you examine them. So we needed to take that into account. The other things that we looked at were things that you would see on examination. So you find things like unusually soft or velvety skin, mild skin hyperextensibility, something called the 10th sign, which I can explain in more detail if necessary later on. Also unexplained striae, things called pysogenic papules, the heel, which are like little sort of fatty lumps that pop out through the connective tissue, recurrent multiple abdominal hernias, and unusual atrophic scarring. Prolapse, as I've already mentioned, but also interesting, dental crowding is something that we see a lot. And also arachnodactyl, and there are a couple of signs that one can use to try and ascertain that. It's important to measure the arm span to height ratio and to listen to the heart, because often connective tissue affects the heart valves, and you get sort of mild regurgitation. Important to look and do an echo for aortic root dilatation too. So those things are really important when it comes to looking at diagnostic criteria, as well as taking into consideration whether somebody has a positive family history. As Katy alluded to actually with her case, it's obviously very helpful when you've got family members who have already been diagnosed with it. But what we're finding is that very often actually there is a positive family history, but other family members have never been diagnosed. So I think we're going to have to kind of look at that again. And then the other three things are really important, which we see a lot, is musculoskeletal pain in 2 or more limbs recurring daily for 3 months at least, chronic widespread pain for 3 months, and recurrent joint dislocations or frank joint instability in the absence of trauma. So there's a couple of links here which you can click onto. One of them actually is that template, if you're ever interested in printing it out and looking at it in a bit more detail. So I'm now going to talk a bit about POTS, and it's really interesting actually, because I know it's one of those things, a sort of cognitive bias type thing, but whenever I look at paintings, all I ever seem to find are women who seem to be reclining. And obviously there was this time in history where male artists just used to spend their whole time painting not just nudes, but women that were just reclining. And I suspect that a lot of them actually had POTS. So yeah, looking at the history of POTS, fascinating really, because it was seen as a sort of male problem to start with. So you get Da Costa in 1871, who kind of came up with this irritable heart syndrome in soldiers who fought in the American Civil War, and then in World War I, soldier's heart. And then moving forwards in 1941, there was this sort of understanding that there were these women that kind of had this anxiety, neurosis, and effort intolerance. And from then on, we've ended up with varying labels for these sort of patients that we now recognise as having POTS, with all sorts of, you know, different labels like vasoregulatory asthenia, etc., etc. But it's really only since the sort of early 80s that we began to recognise exactly what POTS is, and we're getting more knowledge all the time. So postural orthostatic tachycardia, which I'm obviously going to refer to as POTS, it's actually really easy to diagnose POTS, really, really easy. And all you need to do is to get the patient to check their pulse lying, and then to stand up and then check their pulse again. And if the pulse goes up by more than 30 beats per minute, you can be pretty sure that somebody's got POTS. It is absolutely dead easy. But for some reason, you know, we are completely obsessed, aren't we, in general practice with checking blood pressure, lying and standing, but we've never really, up to now, paid much attention to what's going on with heart rate. The other thing that you tend to see is that these POTS patients tend to have a high standing heart rate, often of about 120 beats per minute. And there's often no significant change in blood pressure. The main symptoms tend to be syncope or almost syncope. And I think one of the really important things to get across is that, and certainly this is my experience, is the symptoms really do change day to day and even hour to hour. And so you get these massive fluctuations, which makes diagnosis sometimes quite difficult, because if you go and see a doctor and at the time you're not struggling too much, it's very easy for a doctor to say, oh no, you haven't got POTS. It's 5 times more common in women, and it tends to present between 15 to 50 years. 50% of people have a preceding viral illness, and 25% have a family history. So the other symptoms of POTS, you know, you tend to think of POTS presenting as feeling faint or fainting, but there are lots of other symptoms that people with POTS experience. And obviously this talk is pertaining to headaches, and headaches and migraine are a really common symptom with POTS. And also it's often associated with brain fog, chronic fatigue, blurred vision due really to autonomic problems, I think, but also digestive problems too. This is a slide that belongs to Professor Matthias, and he describes it rather aptly as looking like the Manhattan skyline. And so this is what you see with POTS, is that, as I say, blood pressure doesn't really change very much. So if you look at the yellow, you've got your systolic and diastolic blood pressure, which doesn't really change much. Obviously, it goes down at night. But if you start looking at the heart rate, the red zigzaggy lines, you'll see that as soon as people stand up, the heart rate shoots up and then it goes down again. So essentially, I agree with all this. I read this somewhere, but I thought, yeah, this is absolutely what I experience. You feel awful when you're upright. You feel worse in the morning. You feel worse in warm environments. You feel worse with large meals or alcohol. You feel worse with physical exertion. And I remember thinking before I got diagnosed, gosh, I feel like I'm somebody who I would diagnose heart failure in an elderly patient, with sort of palpitations and just feeling weak and short of breath. So often these patients, usually women, they look really well, but they are disproportionately disabled. And I think this is one of the issues that's been so hard for these women through time. So that's just a photo of me. Always got my feet up. I've got my feet up now, actually, as I'm talking to you. And even on the Chiltern Railways, and sometimes I get some really, some quite sort of nasty looks, because obviously you're not meant to put your feet up on the Chiltern Railway seats. There are signs saying that you shouldn't, but actually I do tend to travel at quiet times, and I find that if I don't, I really struggle. POTS tests. So tilt table test is the sort of, a purist would want to do a tilt table test. I'm not convinced that everybody needs a tilt table test. I think if you just do this, if people have got symptoms, certainly if they've got EDS, and you can check the pulse lying and standing, you can be pretty sure somebody's got POTS. The problem with doing a tilt table test is that I've had quite a few patients who've come back and said they've had a negative tilt table test, whereas I'm sure they've got POTS, but of course, they've maybe been caught at a time when they weren't particularly struggling with problems. And if a tilt table test is done in the morning, they're more likely to have a positive result than say they were given an appointment in the late afternoon. The overlap with POTS and EDS, you're looking at things that tend to involve the gastrointestinal system, the bladder. Chiari, small fibre neuropathy, is also something that you see commonly, POTS with EDS. And as I've mentioned, mitral valve prolapse, and I shall come on to mast cell activation in a minute. So how do we treat POTS? Well, it's very easy, isn't it, for patients to just want to take a tablet and get better without having to change their lifestyle. And one of the things I have recognised is that actually lifestyle is really, really important in the treatment of POTS, and you've really got to get that across to patients. And if you do the right things, you actually can make a big difference to yourself. The most important thing is to increase salt in your diet. And of course, we tend to, as GPs, be telling people the whole time to decrease salt in their diet. But most of these patients do have low blood pressure, and they do feel a lot better when they add salt to everything. They tend to then obviously get more thirsty and will increase their fluids, but they should be increasing fluids anyway. Small, frequent meals. If you have a large meal, you are really done for. You know, you get brain fog, you have to lie down. So just some really simple things can make a really big difference to people's quality of life. Wearing compression tights, really important. And that also really helps with the proprioceptive problems that EDS patients have. Abdominal binders, doing exercise, very difficult issue. There's a fine balance with EDS patients because they often really struggle with pain with exercise, and you have to start really slow and do it in a very sort of incremental, graded way. But actually recumbent cycling is really, really good. And if you can just help people to build up and condition themselves, there can be a huge change in how they, in their quality of life. Referral usually goes to either cardiology, autonomic neurology. There's a shortage of POTS consultants, really. I think it's getting slightly better, and it's certainly much easier in the south. the patients that I see sort of in other parts of the country, it is definitely much more challenging trying to find a consultant who's helpful and understands the condition at the moment, but hopefully that's going to change. This is what I want for my 60th birthday. I've decided when I was looking at slides for this lecture, I came across this and I thought, God, this is what I really, really want, because I used to love playing the piano and I actually find it really difficult to sit upright and play the piano now. So I'm going to have to get my husband to look into this, I think, for my 60th birthday. Moving on, mast cell activation syndrome. So I'm sure you all remember mast cells and probably know quite a lot about them, especially in relation to headaches and migraine. As you know, mast cells get activated and they release bioactive substances, and as a result of mechanical, biological or chemical stimuli. There are lots and lots of chemical mediators that can get released from mast cells. The one that people tend to remember is histamine, of course, but also tryptase, heparin, and heparin can cause problems with bruising, interleukins, prostaglandins, tumor necrosis factor, you name it. And mast cells tend to degranulate with all sorts of different things, parasites, viruses, mold, etc., etc. So the symptoms of mast cell are vast. Your usual kind of allergic symptoms that you would know about: flushing, urticaria, angioedema, rhinitis. 83, the study that I found suggested that 83% of patients with mast cell do struggle with headache, but also things like asthma, GI disturbance, other sort of neurological problems like brain fog, neuropsychiatric problems like anxiety, sense of uneasiness. Interstitial cystitis is a big problem for a lot of EDS patients with mast cell. You can get unexplained fluctuations in blood pressure, chronic fatigue, and syncope. And obviously it can be very difficult then to sort of work out, well, what's POTS and what's due to mast cell. And in fact, 17% of patients do get anaphylaxis. So it's important to remember that, even though it's a non-IgE mediated issue. So we don't really know, I don't think, why mast cells degranulate more readily in EDS. I mean, I was told by Professor Mathias it was because the cell membrane around the mast cell is made of collagen, and because the collagen's weak, it degranulates more easily. But I don't know whether there's actually any evidence for that, but I mean, it's an interesting theory. The difference between mastocytosis and mast cell activation syndrome is to do with the number of mast cells. So in mast cell activation syndrome, you've got the same number of mast cells that you would expect in any other person, but they just degranulate more easily. In mastocytosis, you get an increased number of mast cells and you get an increased tryptase. So that's the difference between the two. Testing is really difficult. So like EDS, you know, you're just so often having to go on a clinical diagnosis, sort of clinical symptoms and examination with these issues. Your tryptase is normal. I mean, when I got tested, all my tests got sent to the Mayo Clinic in America, and actually they all came back normal, but it was clear I'd got mast cell activation just from my symptoms. Because if you miss the time when somebody's having a problem with their mast cells, then obviously you're not catching that window when a flare up. But one of the things that is very almost ubiquitous is that people with mast cell problems tend to have a strong reaction to insect bites. And I think without fail, every EDS patient I've seen who, I mean, the vast majority have mast cell problems, they will have dermatographia, which I'm sure you know what that is, but you basically just, you know, just rub their back and then they come up in this huge wheel and they look really surprised when you take a photograph and show it to them. So how do we treat mast cell activation syndrome? Well, the really good thing about mast cell activation syndrome is that the drugs that you use are actually fairly safe, so you can't really go wrong trying some of these things, even if you weren't sure whether they'd actually got mast cell activation syndrome, and they don't tend to interact with other tablets either. So H1 and H2 blockers, obviously, to help mop up the histamine. And I find fexofenadine is the best drug. A lot of the other non-sedating antihistamines, strangely in EDS patients, tend to cause sedation. That's certainly my experience as well. And I think it's something to do with the fact that we have a slightly different blood-brain barrier, and we let in through molecules that other people's blood-brain barriers don't. H2 blockers like ranitidine, huge problem at the moment getting hold of any H2 blockers. I mean, I had this issue with a patient this afternoon. You can't get ranitidine, you can't get cimetidine, you can't get famotidine at the moment, but generally speaking, you know, they work well. Then you're also looking at mast cell stabilizers, sodium chromoglycate, ketotifen. NHS GPs struggle to prescribe those because they're not familiar with them, but generally they're happy to prescribe montelukast if you suggest it, because they're used to prescribing it for asthma. Interestingly, and you probably know this, but tricyclics have antihistamine activity. So you often find that some of the sort of tablets that you might use as a sort of preventative for migraine, like amitriptyline, dithiopin, or triptyline, actually work very well in mast cell activation. And maybe that's sometimes in these migraine patients, actually it's a mast cell problem that's, you know, the issue behind the migraine. And then you're looking at avoiding triggers, all sorts of different triggers. Heat certainly is a huge trigger for me, and often is with other people. The other really interesting thing is that you get a subset of patients that actually have a low level of DAO, which is diamine oxidase. So diamine oxidase breaks up your histamine in your gut. So clearly, if you've got a low level of that, it's a double whammy. And certainly when my test was sent off to the States, I had a low level of the enzyme. So I now take something called Daosin before food, and that really does help, because it helps to obviously mop up the excess histamine. And then there's things like quercetin, which is an anti-inflammatory, and vitamin C that are meant to be helpful. So mast cell activation syndrome, you know, lots of written about, well, what diet should you go on? Low histamine diet is the obvious one, but it's actually incredibly challenging, because nearly, I mean, it's almost impossible to stick to a low histamine diet. But my rule of thumb to say to people is just eat fresh, because any food that's been knocking around for any length of time tends to have a lot of histamine in it. So it's it's the most sort of straightforward, simple thing to say to people. And fish particularly can be a problem, actually, if it's been hanging around. The gastroenterologist who deals with EDS patients often suggests a FODMAP diet. Didn't make any difference to me, but some people can find it helpful. And then you're looking at things like gluten-free diets, which I'm sure you talk about with your migraine patients. So symptoms are rarely fatal in mast cell, but they obviously can end up exhausting doctors, families, and friends. And I think this is one of the issues, you know, a bit like migraine, actually. It doesn't shorten life, but it can make life really unpleasant, because the symptoms can be really, you know, really affect your quality of life. And some of these patients definitely sort of struggle with post-traumatic stress issues, because they've just had years of not being believed when they're really struggling. The other issue we have at the moment is just aren't enough specialists dealing with this, but hopefully that will change as time goes on. So moving on quickly, how does this, what we call trifecta, which is the EDS, POTS, and mast cell that we tend to see together in this cluster of patients, relate to your patients in your headache clinic? Now, when I sort of sat down and thought about this, I realized there are just like numerous reasons why a headache patient with EDS, POTS, and mast cell they just may have so many different causes for their headache. It's actually just a bit of a headache thinking about it, to be honest with you. So these are the ones that I put down, and you may well be able to think of other things I haven't thought of, but I'll just run through them really quickly. So migraine, obviously, and then psychogenic headache, because your muscles are having to work so much harder in EDS because you haven't got that scaffolding from your weak ligaments. And then obviously the direct relation to POTS, blurred vision from the autonomic problems. Quite a lot of EDS patients have TMJ dysfunction. And then I'll come on to this in a bit more detail in a minute, but craniocervical instability is a huge problem for a lot of EDS patients, and it just doesn't get properly looked at the moment. You've got things like Chiari, CSF leak again, which I think is underdiagnosed. And then things which I know very little about, which you'll know a lot more about, things like idiopathic intracranial hypertension. A lot of EDS patients have arthritis, and obviously got arthritis in the neck that can give them headache. You've got the sinusitis from mast cell issues, trigeminal neuralgia, and then tethered cord. So craniocervical instability we are increasingly recognizing that this is contributing to many of the symptoms in EDS patients. So I suspect that there will be patients coming into your headache clinic who may well fall into this category. And what's interesting is that actually they're often more problematic than those who've got obvious Chiari. So, you know, if you see something on a brain scan, it's quite nice. You can say, oh, somebody's got Chiari, but actually sometimes they don't actually have much in the way of symptoms. But you can have patients who've got craniocervical instability, and it's not really obvious on your normal kind of common or garden MRI scan, and they are really troubled with symptoms. So the only way really to diagnose craniocervical instability properly is to get an upright MRI scan. And that's really difficult at the moment, because the only place that you can really get them done are two places, one in London and one in Manchester, and they're private. It's called MedSerena. And what you're finding is that with these patients that clearly the symptoms are related to compression of the brainstem, related to laxity of the ligaments. I'm sure we're going to be running short of time soon, so I'm not going to run through all of this, but and I know that you'll know it probably better than me, but you know, clearly there are loads and loads of symptoms of craniocervical instability, and what's so tricky and problematic is that it is complex, because so many of these symptoms actually overlap with other conditions and causes of headache. But if you suspected somebody had craniocervical instability, it would be worth thinking about them going for a scan. It is private. If they've got private health insurance, it often is covered on private health insurance. Otherwise, it is a bit more tricky. There are certain things that you can look for. I mean, this is sort of small print. It's probably not worth going into with you in any detail, but it's interesting, and it's kind of ongoing research, really. So how do you manage craniocervical instability? Actually, I mean, I've got craniocervical instability, and you really can get benefit from doing the right kind of neck exercises and wearing a Aspen hard collar. You have to clearly not be wearing a hard collar all the time, because then that weakens the neck muscles. But for example, wearing a hard collar in a car when you're a passenger is quite useful, especially in Bucks where there are so many potholes. If it's very severe, then I'm sure you're going to be looking at referring on to a neurologist and taking things further. And then, you know, do these patients need a neurosurgical referral? You really don't want to be having surgery unless you are really, really struggling, because an EDS patient is already, you know, in a difficult position with surgery anyway, because they don't heal very well. But some poor patients who are really struggling do end up going over to the States or to Barcelona. And there's also some interest in chiropractic and whether you can actually sort of sort out the instability that way. And it's interesting. The other thing that is really fascinating is that there is a school of thought that actually a lot of people who are struggling with ME actually have craniocervical instability, and that is the cause for their symptoms. So moving on to CSF leak. So I think often people will say things like, my headache gets worse when I stand and it almost goes away when I lie down. So again, I'm sure that I'm teaching a grandmother to suck eggs here. You know, that's kind of what you're looking for, isn't it? You know, a headache that gets worse when people are upright, and it tends to improve when they're lying supine. The headache's worse by the end of the day. They have a severe headache all day. In people who are really struggling in non-standing cases, there may be nausea and vomiting, and there may also be tinnitus due to changes in CSF pressure. They also may have neck pain. I think that one of the most challenging things is trying to work out which of these patients with headache, with EDS, has CSF leak and which has POTS. And I also think there may be patients that have both. And so hopefully this kind of table helps you a little bit, but I think it's very difficult because both lots of patients will have a headache. They'll both have headaches that tend to be worse when upright. They will both have neck pain, they'll have fatigue, there'll be nausea possibly. But the sort of things to look out for are, you know, checking the heart rate, because if the heart rate's going up by more than 30 beats per minute and there's no change in blood pressure, then that would sort of lean you towards thinking about POTS perhaps. And POTS tends to cause problems with dizziness, where maybe CSF leak is less likely to. But, you know, it's a very difficult grey area, to be honest with you. So my feeling is, and it is a personal view, of course, is that CSF leak isn't diagnosed enough. I think it's more common than we think. And my feeling is that there's a reticence really to diagnose CSF leak, because it can be difficult to treat and it can be difficult to find. So, you know, you can send somebody for a gadolinium scan, but actually they often come back negative, but it doesn't mean to say they haven't got a leak. And as I say, EDS patients can certainly have both. Managing a CSF leak, I'm sure you know this, you know, telling people to increase their oral fluids, have caffeine, they need epidural blood patches, sometimes more than one. And in really difficult cases, they end up sometimes having fibrin glue or a surgical repair. Chiari malformation, I think I'm going to skip through quickly, because it was interesting for me to learn about it, because I don't really know much about it, but I suspect you being headache specialists, you're already au fait with this. But again, I think upright MRI scans can be useful. Obviously, herniation can cause obstruction to CSF flow. I never knew about this, but I found this really interesting, that you can get this empty cellar syndrome associated with IIH, flattening of the pituitary gland, resulting in hormonal changes. And you do see this association actually in EDS patients with Chiari, craniocervical instability, and this condition called tethered cord. I don't know if you know what tethered cord is, but it's basically where you get fibrous tissue in the around the filum terminale at the bottom of the spine, which then causes traction, which can lead to headache. And I have seen it in a couple of patients. I had one patient who presented with urinary symptoms. That's quite a common way to present. So idiopathic intracranial hypertension, as I say, that's something that can occur. From what I know about it, you often get, or it can be associated with tinnitus, double vision sensitivity to light. So conclusion, lots of different types of headache, clearly, in EDS patients potentially, and certainly in EDS patients who've got POTS and mast cell. So it's complex, and there is an overlap in symptoms, and many patients will have multiple causes for their headache. So each headache needs to be considered in turn to maximize management and reduce suffering and pain as much as possible. So I just wanted to finish by just talking to you for a couple of minutes about an audit. I've actually seen 80 patients in my EDS clinic, and 2 I didn't think had got EDS, but the 78 that I thought had either got hypermobility EDS or HSD, a huge number have incapacitating headaches. So I got a friend of mine's daughter, who's a medical student, very kindly to go through all my notes over the last week, because I think it would have taken me hours to go through it. And we found that 73% of my patients that I've seen have incapacitating headache of some sort or other. It's affecting their quality of life. So it's a really big thing in EDS patients. And from looking at the notes, 58% of these patients who had headache, I would have described as having a migrainous headache. They may have got other reasons for the headache, but migraine is also a big factor here. So this is just a bar chart showing some of the neurological symptoms that my patients had. Headache obviously comes out as a really big one. migraine. And then, you know, a lot of these patients are struggling with concentration and brain fog, visual symptoms. Clearly, a lot have neck and shoulder pain. And then you've got the patients with dizziness, tinnitus, barometric pressure problems, TMJ. And then I had one patient actually that was discharging clear fluid from their nose. So, you know, it's suggestible of a CSF leak. So to conclude, you know, headache, incapacitating headache, it's really common in these patients. Obviously, you know, in my cohort, 3/4 of them were struggling with this. And what I found is that many of these patients, when you talk to them, they've actually tried loads of different treatments for headache, and they often haven't worked. And one of the problems that you're always up against with EDS patients is that they tend to be very sensitive to medication and side effects. So that makes life really quite difficult. I think they are going to be the ones that are going to be attending your clinic, because they're the sort of ones that just have this intractable problem that the sort of GP in their surgery just cannot sort with their usual GP suggestions. And so I suppose what I'm asking you is to sort of think about being mindful of all these different important causes for headaches, and maybe looking at these patients and thinking about, have I got a hypermobile patient in front of me that actually has EDS? So yeah, I think this is probably sort of slightly repeating over what we've talked about before, but it is just thinking about, has this person got POTS? Have they got CCI? Have they got mast cell? Have they got a CSF leak? Have they got a TMJ problem? Have they got more than one problem? And so I suppose it would be quite nice if we had time to sort of discuss how we move forward with these patients that you see, because clearly what I'm very aware of is you probably don't have time to be filling out a diagnostic criteria for hypermobility EDS when you're trying to deal with the headache. And, you know, how do I help you with this? And where are you going to send them if you think they might have got this, or you're unclear what to do? Because I actually think that a lot of the recalcitrant patients in these clinics really do have undiagnosed connective tissue disorder, and that a lot of them are actually being shortchanged because we just haven't really got enough awareness at the moment in education of medical professionals.